Hello and welcome to this critical care teaching video on the management of aneurysmal subarachnoid hemorrhage. In this video we're going to have a look at the causes of cerebral aneurysms, their anatomy, the cardiac problems that we can see in patients with subarachnoid hemorrhage, the physiological targets that we should be using within the intensive care unit, methods of securing the aneurysm, and finally, we'll look at vasospasm, or as we should be calling it, delayed ischemic neurological deficit. When we look at the cause of cerebral aneurysms, we can split these into those acquired risk factors developing over time and congenital and genetic risk factors that we are born with. In terms of risk factors that develop over time, the number one cause of cerebral aneurysms is atherosclerosis, and as a result, all of the conditions that put you at risk of atherosclerosis are on the list of risk factors for aneurysms, including hypertension and smoking. Also drug abuse, in particular cocaine and amphetamines, excess alcohol, and unfortunately older age. Those risk factors we're born with include a family history of cerebral aneurysms, arteriovenous malformations, coarctation of the aorta, polycystic kidney disease, and connective tissue disorders such as Ehlers-Danlos syndrome. In terms of anatomy, it is most common to find cerebral aneurysms within the anterior communicating, posterior communicating, or middle cerebral arteries, but they can occur anywhere within the cerebral circulation, and you will, if you look at different texts, find variable prevalence of aneurysms in different vessels. Cardiac problems are very, very common in patients post-subarachnoid hemorrhage, and that is because subarachnoid hemorrhage will cause a massive sympathetic storm for the patient. A 12-lead ECG is mandatory in admission for these patients, and if it's in any way abnormal, we should be looking at a cardiogram because our patients may need inotropes, and cardiac output monitoring may help guide our therapy. In my experience, though, typically even the worst cardiac impairment does tend to improve given time, and it's been very rarely that I've had to support a patient with inotropes or advanced cardiac output monitoring for more than 5 to 7 days after a severe subarachnoid hemorrhage. How about targets when we admit these patients to our intensive care units then? Well, as ever, we can break these down A, B, C, D, E. So in terms of airway, it's about keeping normal oxygen tensions, 10 kilopascals or above. In terms of carbon dioxide levels, similar to what we would do in traumatic brain injury, aiming for the lower end of the normal range for carbon dioxide. Blood pressure targeting with subarachnoid hemorrhage is slightly different. We look at systolic blood pressure, where I work, rather than a mean arterial pressure. In an unsecured aneurysm, that's one that has not been intervened upon by the surgeons or the radiologists, we would typically keep blood pressure less than 160 millimeters of mercury. That's systolic blood pressure, not mean. When the aneurysm has been secured, we would accept much higher blood pressures, and in fact we may use therapeutic hypertension as a means of preventing some of the later complications of subarachnoid hemorrhage. We'll come on to that in a moment. We want to keep normal levels of glucose, avoiding any hypoglycemia in particular, but also hyperglycemia, which can worsen cerebral edema. Keep a normal body temperature, again trying to avoid pyrexia, and maintain good levels of hemoglobin within the blood, and therefore maintain good oxygen delivery to the injured brain. Patients with any form of brain injury are prone to polyuria, and as such we need to keep careful eye on fluid balance to maintain euvolemia to potentially a slight positive balance. In terms of securing the aneurysm then, there are two options available to us. Where I work, the most common intervention is endovascular occlusion, or coiling of the aneurysm. This is almost always carried out under general anaesthetic and is a difficult and sometimes very lengthy procedure. It's carried out by interventional neuroradiologists taking access to the arterial circulation, typically via the right femoral artery. Platinum coils are then deployed within the aneurysm until it is completely occluded. They will occasionally also use stents in securing the aneurysm as well, and that means your patient may come back to the intensive care unit on antiplatelets, and those are critical drugs. If those stents become blocked by thrombus, that will lead to significant injury to the patient's brain. In terms of risks with endovascular occlusion, during the procedure there is a risk of rupture and rebleeding, which typically is quoted somewhere between 2 and 3%. The other option is the neurosurgical approach, or clipping of the aneurysm. Again, this is carried out under general anaesthetic and is a difficult and time-consuming procedure. A clip is then placed across the neck of the aneurysm. Where I work, this is typically done when an aneurysm is not amenable to coiling, or in a time when an intracranial hematoma is removed and an aneurysm is noted to be at the base of that hematoma as the culprit reason for the bleed. In terms of risks, there is again a risk of rupture and rebleeding, and we've got to consider the effects of the rest of the brain just to access the aneurysm in the first place. So what's best then? Well, in the short term, mortality and morbidity is better for patients who undergo a coiling procedure rather than an open clipping. But in the longer term, there is little difference in outcome. And in fact, some studies have shown that the rebleed rate has been lower with clipping over coiling. That does raise the question, was the coiling done in an optimal fashion in the first place? And I don't think we have the data on that yet. When a patient with an aneurysmal subarachnoid hemorrhage is admitted to the intensive care unit, the main job of the clinicians is to avoid delayed ischemic neurological deficit. This is not fully understood, but we do know that the autoregulation of cerebral blood flow is affected by blood in the cerebrospinal fluid. This was previously referred to as vasospasm, but we have noted over the years that secondary brain injury will occur throughout the brain, not just in those territories that are affected by vasospasm, hence the move away from that term. In terms of preventing delayed ischemic neurological deficit, there are a few different options available to us. The first is the calcium channel blocker Nimodipine. Secondly, we've got so-called triple H therapy, or as it should be termed now, simply H therapy. We'll come on to why in a moment. And there have been multiple other things studied. Nimodipine is a calcium channel antagonist that can cross the blood-brain barrier and is typically given for 3 weeks following the date of subarachnoid hemorrhage. The original trial that found benefit from nimodipine was the British aneurysm nimodipine trial, published in the British Medical Journal back in the late 1980s. Approximately 275 patients in each arm, and they found a lower rate of infarct and a better outcome for the patients that received nimodipine compared with the placebo. They also found reductions in death and rebleeding rate with nimodipine, but these didn't reach statistical significance. It's obviously a vasodilator, and as such, in theory, prevents vasospasm. However, we also know that it reduces delayed ischemic neurological deficit in arterial territories which were not affected by vasospasm, and that is thought to be working through its effect on apoptosis, programmed cell death, which is calcium channel mediated. Triple H therapy then refers to the combination of hypertension, hypervolemia, and hemodilution, and physiologically this is a very sensible approach. If we look at the Hagen-Purcell equation for blood flow, we can improve blood flow and therefore oxygen delivery by increasing the pressure, delta P, or by reducing the viscosity of the blood, hemodilution and hypervolemia. But does this work? Well, a systematic review was carried out in 2010 that looked at the effect of different components of Triple H therapy on cerebral perfusion in patients with aneurysmal subarachnoid hemorrhage. They looked at 11 different trials. In terms of hemodilution, there was no effect on cerebral blood flow, despite the, as earlier mentioned, sensible physiological rationale for taking that approach. In terms of hypervolemia, there were 7 studies looked at that looked specifically at hypervolemia, and only one found a statistically significant increase in cerebral blood flow compared with baseline, and that trial had no control group. My own experience of hypervolemia has actually been that it can potentially be dangerous. I've certainly met patients that have been pushed into pulmonary edema and fluid overload by overzealous people on wards giving excess fluid to patients with subarachnoid hemorrhage. When we look at hypertension, there were 4 studies included within that systematic review, of which 2 found an increase in cerebral blood flow, but again, no control group. Finally, if we look at all 3 components of Triple H therapy implemented in a single patient, there were only 2 studies, and only one of these found an improvement in cerebral blood flow, and once again, there was no control group in that study. So there really is not a lot of good quality evidence for Triple H therapy in the management of people with subarachnoid hemorrhage. So with that in mind, what should we be doing for our patients? Well, we should be giving them all Nimodipine. Locally, we use 60 milligrams of Nimodipine every 4 hours, but if hypotension becomes an issue for us, we split that to give 30 milligrams every 2 hours, so they're getting the same 24-hour dose. We also look to avoid hypovolemia, and typically we will target the patient's fluid balance to be about 500 mL positive per day. We pay very close attention to this because it can become problematic in any patient with any injury to the brain. If the patient has higher insatiable losses such as pyrexia or vomiting, diarrhea, we'll obviously review that fluid target and may increase it. We also will induce hypertension if we are seeing clinical evidence of delayed ischemic neurological deficit. So that GCS that was sitting nicely at 14, 15, if that starts dropping, we will drive blood pressure up for our patients. If we have a central line available to us, we will use noradrenaline. If we don't, we will often start with metaraminol to bridge us to placing that central line to allow us to use noradrenaline. Many other things have been trialed to try and improve outcome for people with subarachnoid hemorrhage. These include magnesium, NMDA receptor antagonists, free radical scavengers, chelating agents, etc. Unfortunately, none of these have proven to be of benefit yet. So today then, we've looked at the etiology and anatomy of aneurysms. We've touched on some of the cardiac problems that we can see in subarachnoid hemorrhage. We've looked at some of the targets we should be shooting for the management of our patients with subarachnoid hemorrhage within critical care. We've talked about the methods available to secure the aneurysm and the management and prevention of delayed ischemic neurological deficit. I do hope you've enjoyed this video. If you do have any questions or comments, please leave them down below, and I hope to see you on the next one.